All right, well, it's great to see such a nice crowd here for the President's Lecture at our 80th Annual CPDD Conference. I hope you're all having a good time so far and enjoying the science and the sunny weather. It's my extreme pleasure. This is the one choice I get to make about the conference to decide on who's going to give the President's Lecture, and I'm very pleased with what we came up with, which is I'd like to start by a shout out to Steve Shoptaw, who I saw came in here. I was looking for a speaker or speakers to speak on social determinants of health, and I put out some feelers to help me with this, and Steve sent me this way to get Dr. Strathy and Dr. Stockman, and I couldn't be more pleased. I think we're going to get just what at least what I was looking for. And so we have research scientists who are doing highly meaningful work that would be of keen interest, I hope, to almost everybody in CPDD. I would hope everybody, but I'm sure most of our membership at least. What I'm going to do first is introduce both speakers. I'm going to start with our second speaker, Dr. Jamila Stockman. She's the Vice Chief and Associate Professor in the Division of Infectious Diseases and Global Public Health in the Department of Medicine at the University of California, San Diego. So we also have two locals. I thought was pretty cool. She directs the iStrive Research Lab investigating syndemic and trauma-related influences on HIV etiology. She received her PhD in epidemiology from Johns Hopkins Bloomberg School of Public Health, Master's in Public Health from George Washington University Institute School of Public Health, and her postdoctoral training at UCSD with our second speaker. She's her mentee. Dr. Stockman has dedicated her career to improving the lives of women with experiences of intimate partner and sexual violence. Her research focuses on the intersecting epidemics of intimate partner violence and sexual violence, HIV acquisition and transmission, and substance abuse among marginalized populations. She's working to advance the understanding of the underlying immunological and physiological mechanisms linking these epidemics, and working to develop interventions to provide maximal reductions in HIV, substance abuse, and violence against women. Currently, she conducts work all over the place, in the US-Mexico border, Latin America, and the Caribbean. In addition, Dr. Stockman actively collaborates with local public health departments, community-based organizations to ensure ethical and cultural appropriateness of her research among members of the community. She also serves on various domestic violence prevention steering committees, community-based organizations working to address the deleterious effects of violence and HIV in families and relationships. She has many peer-reviewed publications. As far as I can see on her CV, she has multiple large federal and state grants. She's truly a person that's doing it all, and I'm so glad she could make time to participate in our program this week. Thank you, Jamila. Our second speaker is going to be Dr. Jamila's postdoctoral mentor, Dr. Stephanie Strathy. She's the Associate Dean of Global Health Sciences and the Harold Simon Professor in the Department of Medicine at the University of California, San Diego School of Medicine, and she's an adjunct professor at Johns Hopkins and Simon Fraser Universities. Dr. Strathy is director of the UC San Diego Global Health Institute. She co-directs the Fogarty-funded GLOCAL program, offering global health fellowships to U.S. students, fellows, and international collaborators, and she co-directs the UCSD Center for AIDS Research International Core. She received her MS and PhD from the University of Toronto, Department of Preventative Medicine and Biostatistics. Her work, she's an infectious disease epidemiologist who has spent the last 2 decades focused on HIV prevention in underserved, marginalized populations in developed and developing countries, including injection drug users, men having sex with men, and sex workers. In the last decade, she has published over 600 peer-reviewed publications. That was 600. So for the younger people in the audience, you got some time to do that. The rest of us, too late. Her publications focus on HIV prevention, the natural history of HIV and related infections, and the evaluation of interventions to reduce harms among substance-using populations. Currently, she's engaged in a number of HIV STI prevention projects in international settings in Mexico. She also leads several NIH-funded studies of HIV risk behaviors among drug users and sex workers on the Mexico-US border. One is which is funded by an NIH Merit Award granted by NIDA. Currently, again, from what I could tell on her CV, she has 4 active grants from various sources. She's co-PI of a T-32 NIDA training program. She's won numerous awards and provided a tremendous amount of service in various positions to the NIH and other key research and policy institutes and organizations around the world. And I'm so pleased, as with Dr. Stockman, that they both agreed to team up and provide the President's Lecture. So thank you very much for your time. It's all yours. Warm welcome, please.
Thanks very much, Alan. I was just thinking, wow, after an introduction like this and the great honor of giving the President's Lecture along with Jamila, I can probably die after tonight. But people in the audience may be really excited to see, oh wow, there's 2 people from San Diego presenting, and other people might be excited because there's 2 women giving the President's Lecture, or other people might be excited because we're representing diversity. But to me, I'm most excited to be presenting with Jamila as one of my mentees, because to me, CPDD represents a network, an opportunity to nourish and allow the next generation of substance use researchers to flourish. And that's what it represents to me. So today, if you take anything away from this, that's what we should be doing. More mentorship. We have a lot of work to do, as you're going to see in this presentation. So I'm going to be giving kind of a 20,000-mile view of the state of our country's epidemic of opioid use especially, and substance use more generally, and some of the health consequences. And then Jamila's going to drill down. So first I'm going to talk a little bit about the epidemiology of prescription and non-prescription opioid epidemics in the US and their underlying drivers. And then I'm going to talk about some of the structural barriers to accessing medication-assisted treatment. And then I'll give 3 case studies that I've been involved in to various extents, and talk about some of the structural interventions that might be implemented to try to ameliorate these epidemics. So the first slide here is, you're going to see repeated through this presentation. This is adapted from a paper by one of my other mentees, Kitty Poundstone, from the Annals of Epidemiology in 2004. It was developed for the HIV epidemic, and we've adapted it here for substance use. And when we're talking about social and structural determinants, we're really talking about factors that are exogenous to the individual. But individual factors matter too. So we see this as kind of an onion. On the outside, there are structural factors at the macro level, for example, war and militarization or demographic changes, structural violence and discrimination, and then the policy environment. Whereas at the social level, we have different behaviors or social capital, cultural norms, neighborhood effects, social networks, socioeconomic position, and legal structures. So we'll give some of these examples today. But first, let's step back a moment and think of where we are. This is not a heading from the Lancet or JAMA. This is the New York Times. And this is a slide that Nora Volkow uses regularly because they were ahead of the game in terms of counting some of the overdose deaths that we were seeing that have mounted over the last decade. We're in a situation now that for the last 2 years, we've had over 60,000 people die from drug overdoses in the United States. Count at 60,000. That's more than people who have died from car crashes in its peak in 1972. That's more people that have died when the AIDS epidemic was at its peak in 1995. That's more than the people that have died due to gun deaths at its peak in 1993. Or all of the people that were killed in the Vietnam War. That's about 58,000 people. More people are dying each year in this country due to overdose. Now, all overdose isn't equal, and we'll take this apart in a minute. But it's important to realize that life expectancy in the United States has dropped for the last 2 years, in a country that's one of the richest in the world. And now overdose is the leading cause of death for US residents less than 50. So these are really stark observations that today should be slapping every one of us in the face. But of course, when we talk about drug overdoses, we're talking about a whole mishmash. But when we break it down by different types of drugs, synthetic opioids have accounted for more than 20,000 overdose deaths within the last year that we have data available, which is 2016. And that peak there is mostly due to fentanyl, and that's here. That's not going to show up. Well, everybody can see it. This slide is actually pretty famous by now. Number 2 is heroin, not surprisingly. And the third peak is natural and semi-synthetic opioids, for example, oxycodone or hydromorphone. And one thing that is really important to pay attention to is that cocaine and methamphetamine overdose deaths have been rising as well. And most people are using a combination of drugs together. So we shouldn't just focus on, fentanyl or just on heroin. We should be looking and parsing out these data to the extent that we can. Now, these deaths have taken the country by storm. Now, whether you're on the left or you're on the right, you cannot avoid the fact that this is a public health emergency. Even President Trump said it. It's one of the few things that I agree with him on. But when we're looking at the pressure that our different funding agencies like CDC and NIDA are under right now, it also should be putting pressure on us as individuals to make ourselves accountable, because most of us are receiving, federal funds to be able to make an impact. So we need to be holding ourselves accountable. Now, going back to our conceptual framework, I want to talk about some of the underlying drivers that have accounted for some of these observational epidemiologic trends. So, for example, the prescription drug use epidemic. Now, from 1999 to 2016, the amount of prescription opioids that were dispensed in the United States nearly quadrupled. And a recent JAMA paper was published that showed an association between marketing of prescription opioids to physicians and their prescribing behaviors. It doesn't take a rocket scientist to figure out that there was something going on here. So these are economic and market drivers. But we've known about this for a while. Even though this is an ecologic association, if you look at the relationship between the sales of prescription painkillers and the overdose deaths due to opioids, there is a trend here that we can go back to see, like from the early 2000s. So even though this isn't causal by any stretch, I am an epidemiologist, we don't, correlation is not causation. But, somebody should have been looking at this and thinking, this is going in the wrong direction here. We should be watching this. And unfortunately, it was a bit too late. However, we have seen some successes. Over the last couple of years, there have been attempts to regulate pain clinics and to set requirements for state public, the prescription drug monitoring programs, and we have started to see in a couple of states decreases in opioid prescribing. Now, sometimes this comes at a cost because we're making opioids more difficult to obtain for even people who have chronic pain. So we have this situation that we really need to be careful about. But these are natural experiments to some extent in different states, and we should be taking the opportunity to evaluate it and to inform policy accordingly. Now, this is a slide that comes courtesy of Ned Nunez and his team. He had the bright idea of looking at the HIV treatment cascade and saying, we should be looking at the opioid treatment cascade. And so this is the cascade of care for opioid use disorders using estimated data or drawing from estimates from publicly available data. So on the left, we have estimates of the number of people in the United States who have severe opioid use disorder. And you can see that it's almost 2.5 million. And the next bar are the proportion of people who have been diagnosed with an opioid use disorder. And in the dark blue there is the treatment gap. If our goal is to have 90% in each one of these bars identified and on treatment, then you can see that as we go from the left part of your screen to the right, that have the diagnosis of opioid use disorder, to engagement in care, to initiation of medication-assisted treatment, to retention in treatment, and continuous abstinence, that gap is widening substantially. But one of the biggest gaps is from diagnosis to care, and from care to initiation of medication-assisted treatment. We only have about 10 to 15% of people who are severely addicted to opiates receiving medication-assisted treatment at any given time in this country. That number has been relatively flat for a long time. So what the heck is going on? We've got methadone maintenance, we've got buprenorphine, we've got naltrexone. Why aren't people getting these treatments? That's what we should be asking ourselves. Well, here's one slide, and considering some of the policy drivers. Now, I'm Canadian. I come from a country where we have socialized medicine, and it's taken me a long time to understand what's going on in this country, and I can't still say that I do understand why we have a situation where Medicaid coverage for methadone maintenance, which we know is the most important treatment for opioid dependence, is still not reimbursed across the board. This is a slide that shows the states that allow Medicaid coverage for methadone maintenance in green versus those that have no public coverage in red, and those that have some coverage through other public programs in yellow. So as you can see, there's about 15 states that have no Medicaid coverage for methadone maintenance. That's one of our big problems in this country, and that really needs to change. But we have other problems too. For example, with buprenorphine, we know already that it's very difficult for some providers to get waivers to allow them to prescribe buprenorphine. That's the problem that's been identified. But what you may not know is that there is a new federal law that allows nurse practitioners to prescribe buprenorphine. And yet, there are laws in 28 states that restrict the nurse's scope to do so. So as you can see here, in the light green is that are states where there's limited scope of practice for nurse practitioners to prescribe buprenorphine. So what we're seeing is that we have structural barriers to getting treatment to the people. And we need to erase these if we're going to be making a dent in this opioid epidemic. So now let's go back to our conceptual framework and consider how some of these different levels of drivers, these social and structural factors, may interact to cause addiction and their health consequences. The case study that I want to present to you is one that may be a familiar one, Scott County, Indiana, where we had an HIV and opioid addiction intertwined epidemics that peaked in 2015. Now, Scott County is the poorest of all of the counties in Indiana. It has 10% unemployment, almost 1/5 live below the poverty line, 1/5 without a high school diploma. It's last in life expectancy out of 92 counties in the state. And in Austin, which is the epicenter of these intertwined epidemics, there was no addiction treatment facility at the time that this epidemic occurred, not a single one. Now, but it gets worse, because this is a setting where there were pill mills providing easy access to prescription opiates. There was actually intergenerational drug use where, grandparents and their kids were all injecting drugs together. There was a change in the drug formulation that made it more difficult for people to use and inject Opana, so they switched over to using heroin. We should have seen this coming, and yet we didn't. In terms of the perfect storm, needle exchange programs were illegal. Indiana is a red state. It was actually a federal crime if you possessed a syringe without a prescription. There were very few HIV testing clinics. In fact, 5 Planned Parenthood clinics that provided HIV testing were closed down because they provided abortion. So they were closed down for that reason, but what that meant is that people who were concerned about their HIV serostatus couldn't access testing. There was delayed Medicaid expansion because there was fights between the red and the blue parts of our government. And as a result, there was no easy access for health care and, as I mentioned, no MAT. So there was this massive HIV outbreak, but we should have seen it coming. There was actually a rise in hepatitis C prevalence in the same region several years beforehand. There were people who noticed this. My colleague Jennifer Havens is in the audience. She's in nearby Kentucky. She was telling people for years, something's going on here. We're going to have a big problem, and she was right. So this is a part of the state, Indiana, that used to see about 5 HIV cases a year. In 2015, they had 166 new HIV cases. And when they looked closer, there was an outbreak investigation led by the CDC. They saw that it was a point source epidemic. That means really that the epidemic started like a match being dropped into a tinderbox and took off. But it didn't just affect injection drug users, it affected their sexual partners, it affected children. And so this should be a lesson to us all. In Austin, it's a city, or town really, of 4,200 people. The community-wide HIV prevalence is now 4.2%. Now, just for those of you who aren't HIV researchers, a generalized epidemic, according to the World Health Organization, is 1% HIV prevalence in the general community. Okay, so this could be what we end up seeing if we don't get our opioid epidemics in check. So just going back now to our conceptual framework, let's talk about some of the legal structures. Now, our criminal justice system has actually contributed to a lot of these problems as well. The estimated number of adults incarcerated for drug violations in the United States has increased terrifically over the last 40 years. We have over 2 million people incarcerated. We incarcerate more people in the world than any other country, even Russia. And in terms of legal drivers, policing and incarceration both play a part. And there have been steps to overturn this. For example, having Good Samaritan laws so that when someone overdoses and calls 911, that they aren't subjected to criminal prosecution for drug possession. But even this headline from the New York Times shows that these Good Samaritan laws aren't always being respected. And so some people are present at the time of an overdose and they're being charged with homicide, which is just absolutely asinine, if you ask me. Now, this fellow, Jerome Adams, was the health commissioner in Indiana during the Scott County outbreak. And he saw this happen, and he was responsible with the CDC for the response. He is now our Surgeon General. And he did something really amazing recently. He came forward with the first Surgeon General's advisory in 13 years, and it's telling all the people in the United States to carry naloxone. It took a tremendous amount of guts for him to do this, and I'm absolutely 100% behind him. But we still have structural barriers. Just because the Surgeon General tells somebody that we should all be doing this, it doesn't mean that we can do it. For example, the cost for generic naloxone is $20 to $40. Nasal naloxone is really expensive, and it's not covered at all by any of the health insurers. And there's low awareness and risk perception. For example, the Needle Exchange here in San Diego doesn't provide naloxone. They're worried about liability. So we're not getting through. These barriers really need to be unpacked and intervened upon. My colleague, Peter Davidson, leads a study funded by NIDA here in San Diego. He's studying the impact of sheriff deputies' use of naloxone on people who inject drugs' willingness to call 911 for an overdose. So these kinds of things are policy interventions or natural experiments to be able to see if we just kind of tweak the risk environment a little bit, can we make a difference? These kinds of innovative ways of doing science are different than many of us are trained, but I think that they're the way forward. Now, the second case example I want to briefly touch on is what's happening in Mexico. We're 20 minutes away from Tijuana, which is one of the research programs that I lead, and we've had a major war on drugs that is linked very closely to that in the U.S. And we've done a research study that I won't have time to tell you all the results, but we have had thousands of people living in the Tijuana River Canal. And this is actually, in the background, is the wall to the United States. This one, and all of these photos are with permission, by the way. The woman on the left-hand side is Martha Patricia. She's a friend of mine. She has HIV, she has hepatitis, and she has active TB. When I called the HIV STD coordinator for Tijuana, because she's one of our participants and I was trying to get her some help, I said, you know, she has active TB now and she's a sex worker. Can we get her some help? And they said, well, you can put her in the rehab outside of the city and we'll give her a voucher so that she can come to the clinic every day, which would mean she has to spend 2 hours on the bus. That's what I'm calling structural barriers. So I actually paid for a motel room for her for a couple weeks so that we could get her some treatment. We have a long way to go. Now, in Tijuana, our research team has shown that policing practices are directly associated and independently associated with HIV infection. And this is due to a number of factors. For example, the police confiscate their syringes and break them, and they make drug users feel like they have to go to shooting galleries to avoid the police. This causes people to share needles and to become infected with HIV. The police also drive them away from using needle exchange and methadone treatment. And this is actually a photo of police waterboarding some of our participants in the Tijuana River Canal, which we reported. And as a result of seeing these associations over and over again, I realized we can't just be telling people not to share needles because it's the police, stupid. It's like we have to think more broadly than this. So, and in fact, before I show you what we did, this type of police violence, this structural violence that has occurred, there was an operativo, a police effort to drive people into drug abuse treatment. And so they took hundreds of people that were living in the Tijuana River Canal and forced them into drug treatment. Now, mind you, there's no methadone available, so this was not real treatment. This was forced treatment. And one of my PhD students, Claudia Raful, who is here, who won awards for this research, found that involuntary drug treatment was associated with a higher risk of non-fatal overdose following leaving these programs. We gave these results to the Mexican government, and unfortunately, they have not stopped this program yet. So again, sometimes policy works, and sometimes we have a longer slog. But we have a bit of good news from Tijuana that I'll share with you now. We have tried to create an enabling environment by using policies and laws to promote health instead of risk. And one of the projects that we developed with help from NIDA is called Proyecto Escudo, which is a police education program. So my colleague, Leo Beletsky, is the brainchild behind this. He said, you know, police might not care about the health of a drug user, but they care about their own health. So if we show them that if they are taking needles away from a drug user and breaking it, that they're putting themselves at risk of a needle stick injury, then, you know, perhaps we can get them to change their behaviors. So we've bundled public health education with occupational health and safety. And we have some preliminary data that suggests that after exposure to our intervention, and we've actually trained over 1,800 police officers in Tijuana, that they changed their attitudes about syringe exchange programs. They thought that they were harmful before, but now they see that they can actually, you know, reduce the risk of a needle stick. They see now that it's actually the role of a police officer to refer drug users to health and social services. And they also have started to believe that methadone maintenance reduces criminal activity. So the results of this study are still being analyzed, but we're hopeful that we can turn the tide. And here's just a photo of our wound clinic in Tijuana, where some of our staff actually, on their own spare time, are providing care and abscess treatment to the participants in our project. Now, the last case study I want to turn to is from Vancouver. When I was a postdoc, I ended up in Vancouver, where we ended up having the highest HIV incidence among injection drug users in the Western world. And we also saw an increase in overdose. So we saw a lot of the same things that we're seeing now here in the United States. And we published a paper on Vancouver's deadly public policies. We talked about the deinstitutionalization of people who are in mental health facilities, the gentrification of the poorest neighborhood, the funding cuts to social housing, the syringe exchange that was going on versus the distribution that was very limited, intensive incarceration, and what we also call welfare Wednesdays, where people were getting their welfare checks all on the same day each month, which allowed them to pool their money and use drugs all at the same time. So it sounds kind of familiar, a lot of the same phenomenon going on here. But what Vancouver did was have a public health response that was based on 4 pillars. They scaled up, Matt, in the city and even in the hospital. They decentralized syringe exchange programs. They provided HIV treatment as prevention, and they developed innovative harm reduction approaches such as a safe injection facility called Insight, as well as a heroin prescription program. So this is a photo of Insight on the outside. And this is what it looks like on the inside. And I visited this facility. The study that I started in 1996 was actually used to evaluate this program, which is one of the things I'm most proud of. Now, people might think a safer injection facility, doesn't that make people use drugs more? Isn't that going to cause more, drug use and overdose? In fact, this is probably one of the most rigorously evaluated drug intervention programs that I'm aware of. There has not been a single overdose on site. There's been no increased drug use. There's fewer needles on the street. All of these have been published in some of the top journals. Less needle sharing, increased referrals to detox and methadone maintenance, less public disorder, and decreased overdose mortality. And in particular, this is a paper from Brandon Marshall, who might be in the audience. He published in Lancet and found that there was a 35% reduction in fatal overdoses in the area around the safe injection facility. And one of the things that was interesting as well is that they didn't just focus on the interventions. They actually helped the community itself organize. The Vancouver Drug Users Organization formed and led a number of peer-based interventions. And as a result, it wasn't a surprise to me that this was a headline on one of the papers, that the local church that used to be against the safe injection site actually had a banner, "Save the Safe Injection Site," when the federal government was trying to shut it down, Sunday worship at 10:30 a.m. So the community support had led to a change in social norms. So with that, I'm going to hand over the podium to my colleague, Jamila Stockman, and I thank you for your time.
Thank you. It's an honor to share the podium with Dr. Strathy, who I call Steph. So with that, let's get going. I'm going to focus the remaining portion of my address on 4 sources of traumatic stress, all of which have been implicated as contributing factors to substance use or substance abuse. I will end, sorry, I'm short here, so I'm trying to take a look here and make sure I'm going through the slides appropriately. I'll end by highlighting the role of epigenetics in the context of addiction, while capitalizing on the underlying sources of traumatic stress. So turning our attention back to the conceptual framework that guides our research, I'll first focus on child sexual abuse and intimate partner violence, both considered social level factors that can be influenced by individual characteristics. I'll conclude each section with a brief discussion on the role of policy environment in terms of developing structural level interventions. So child sexual abuse, also known as CSA, is a form of child abuse that includes sexual activity with a minor. It does not need to include physical contact between a perpetrator and a child. And the statistics, when we think about CSA, are quite startling in that 1 in 10 children will be sexually abused before the age of 18. And about 90% of victims know the perpetrator who has sexually abused them. Also important is that 1 in 5 children have been solicited sexually while on the internet. And the internet has really become an emerging area of research in that it provides additional context as to which victimization and perpetration can be initiated online and carried out in real-world practices. So taking a closer look, CSA has been documented as an established risk factor for substance use during adolescence and adulthood. In a meta-analysis of 12 studies, they found that MSM with a history of CSA were more likely to report substance use and sex while under the influence of alcohol or drugs. And when we look at the association between CSA and substance use, we can drill down and look at injection drug use. And this particular study by Hadlin and colleagues among youth in Vancouver showed that there was an increased risk of initiating injection drug use among youth who reported a history of CSA. There are differences by gender have also been observed, with women who inject drugs being significantly more likely to report a history of CSA compared to men who inject drugs. Understanding CSA and substance use also requires us to understand the role of adverse mental health. And as associations have been documented between CSA and substance use, mental health has been explored as a potential mediator in this pathway. Specifically, the relationship between CSA and substance use, specifically when we think about severity of CSA, has been shown to be mediated by PTSD. And this really supports the self-medication model, which posits that those who drink alcohol or use drugs to cope with distress because they believe it will reduce stress actually have more PTSD symptoms, not less. The association between CSA and mental health has been documented among a handful of studies among people who use drugs. Specifically in the United States, among women in methadone treatment, CSA has been shown to be associated with increased risk of PTSD and psychological distress. It's important to note that this has not been just limited to CSA, but has transferred also to childhood emotional neglect. Similar findings have been observed in international settings, specifically in South Africa among men and women who use methamphetamine. CSA was shown to be independently associated with higher substance use coping. So given the association between CSA and substance use and the potential mediating pathway observed by adverse mental health, it's important to look to structural level interventions and ways in which we can intervene. There are two ways that I've noted here. Post-victimization services that are geared towards children and adolescents who disclose child sexual abuse should integrate substance abuse prevention models and programs. Similarly, addiction treatment programs should incorporate not only services for survivors of CSA, but also services that help children and adolescents who experience CSA deal with the adverse mental health effects. Now turning our attention to intimate partner violence, or IPV, it's an epidemic that is widespread, affecting both women and men. In the United States, 1 in 4 women and 1 in 9 men have reported a history of lifetime IPV. Sexual violence, one form of IPV, but not solely limited to intimate partners, that it can also translate to non-intimate partners, also affects both women and men. In that, about 1 in 3 women and nearly 1 in 6 men have reported a lifetime experience of sexual violence. And when we look at intimate partner violence, we can look at it from the perspective of victimization and perpetration. 3 different pathways have been elucidated to explain the association between IPV victimization and substance use. The first is that substance use increases the risk of IPV. And this is due to the cognitive alterations such as impaired judgment, memory, and misunderstanding of partners' behaviors or comments caused by the pharmacological effects of substances. In addition, people who use drugs may be more vulnerable because of their impaired ability to recognize and avoid perpetrators, or because of increased risk that's put forth by the environmental context or setting. The second pathway is that substance use can be used as a coping mechanism for victims of IPV. And there have been numerous studies that have documented higher prevalence estimates of the use of illicit drugs, as well as engaging in alcohol use and abuse for victims of IPV, both men and women, compared to those without such experiences. The last mechanism that has been uncovered is the bidirectional relationship, in which IPV enhances the risk of engaging in substance use, and substance use intensifies the likelihood of being re-victimized by partners, with the consequence of increasing substance use. Now turning our attention to IPV perpetration, both quantitatively and qualitatively, there's been documentation that perpetrators are more likely to use illicit drugs as well as engage in alcohol use. So taken together, when we think about interventions that have been implemented, developed and implemented to address both of these public health issues, we've made some progress. So I've highlighted two here. The first focuses on IPV victimization. And this intervention was conducted by Gilbert and colleagues, and it sought to examine the preliminary effects of a screening, brief intervention, and referral to treatment model to address gender-based violence among women who use drugs. And what Gilbert and colleagues showed was that compared to baseline at 3-month follow-up, women reported experiencing improvement in the IPV incidence, so fewer physical IPV incidents and reduction in illicit drug use as well as injection drug use. What was important here is that also at follow-up, there was a 12 times more likelihood of women who had completed the intervention or assigned to the intervention group to receive GBV-related services. So this showed that women went beyond the referral stage and extended that to being able to actually receive services. Related to perpetration, Stewart and colleagues conducted an RCT that examined the incremental efficacy of a 90-minute motivational alcohol intervention as an adjunct to a standard batterer intervention for men. And compared to baseline, men reported fewer drinks per day, greater alcohol abstinence, and less severe physical aggression. But it's important to note that these effects there were improvements at the 3-month follow-up period. Improvements waned over time. So at the 6-month and 12-month follow-up period, there was no significant improvements in both of these outcomes. So we have a long way to go in terms of developing and implementing interventions that can have long-lasting effects in terms of improving IPV and substance use outcomes. Similarly, we have a long way to go when it comes to examining IPV and substance use and addressing these as treatment barriers. So in terms of treatment facilities, a woman or a man often has to make the choice as to which form of treatment they would like to receive. There's lack of integration in terms of service provisions for IPV and substance use. And so it's really difficult for a woman who is suffering from both IPV and substance use to get the comprehensive care that she needs. So with that, there are many different recommendations at the structural level. At the provider level, there needs to be cultural competence in terms of training in the aspect of both IPV and substance use. There also should be adequate screening of clients for both of these issues, and referral information needs to be offered. At the agency level, there needs to be dedicated case management, and this is often difficult given funding limitations. So there are alternative methods that can be used, such as peer navigation approaches. And we know that peer navigation approaches have been shown to be effective in terms of improving HIV care outcomes, as well as outcomes related to cancer treatment. There also needs to be crosstalk between domestic violence agencies and addiction treatment facilities in terms of examining a particular case. Improvements in service accessibility is also critical. We know that in rural environments, there's often limited access to both domestic violence agencies and services, as well as substance abuse treatment facilities. We know that this is often due to stigma that exists in rural environments, and so we need to capitalize on the innovative methods that are currently underway by using technology to reach these marginalized populations. Related to policy, of course, training and continuing education credits are needed, but most importantly here I want to highlight is the need for gender-specific treatment approaches. And this is critical given the research that has been uncovered to date, showing that women have markedly different experiences relative to men in their initiation into substance use, their pathways to addiction, as well as markedly different substance abuse recovery needs. So now I'd like to turn our attention to highlight the structural level factor of discrimination and the social level factor of incarceration. Both, again, these factors can be influenced by individual level characteristics. Perceived discrimination can be thought of in two different lenses. So for members of disadvantaged groups, attributions to prejudice are likely to be internal, stable, and controllable, and convey widespread exclusion and devaluation of one's group. For members of privileged groups, the meaning of attributions to prejudice is more localized. Perceived discrimination or discrimination has been documented extensively as a health-related stressor, and we know that discrimination comes in many forms, whether it be race, ethnicity, due to incarceration, substance use, disability, sexual and gender identity issues, among many others. And discrimination may or may not result in substance use as a means to reduce the negative adverse mental health effects. So the purpose of this talk, I'm going to touch upon racial discrimination and discrimination specific to substance use. There have been numerous studies, longitudinal and cross-sectional in nature, focused on many different populations, from African American adolescents, African Caribbean adults, Native Americans, Latino men and women, that have consistently showed that perceived racial discrimination is associated with increases in substance use. In particular, Clark and colleagues demonstrated that not only is racial discrimination associated with increases in substance use, but again here, the theme around adverse mental health issues, that depressive symptoms partially mediated the relationship between perceived discrimination and lifetime substance use, and fully mediated the relationship for recent substance use. So we can see again the importance of really highlighting the role of adverse mental health in all of these intersecting epidemics. Gender differences have been shown, with more cumulative perceived racial discrimination being linked to more substance use among men. And socioeconomic position as an effect modifier has been uncovered. So this particular study by Carliner and colleagues found that among Black men and women of high socioeconomic position, those experiencing racial discrimination had about were 3.5 times more likely to report illicit drug use. But no significant association was found between racial discrimination and illicit drug use for Black men and women who reported low socioeconomic position. So that's kind of a shocking finding. And what this finding does is it supports the theory of relative deprivation, which is defined as the individual frustration produced by a negative comparison with a reference group. So in this case, for higher socioeconomic position Blacks, the opportunity for comparison may be more common due to interaction with white neighbors and colleagues, which may intensify the overall frustration. Compared to low socioeconomic position Blacks, higher socioeconomic position Blacks' awareness of this inequity may exacerbate the insults of racial discrimination, resulting in greater psychosocial distress and increased risk for drug use as a coping behavior. Alternatively, to explain the no association found between racial discrimination and illicit drug use for Black men and women of low socioeconomic position, well, they may experience more adverse forms of life stress related to their environment and economic status. So racial discrimination may not be at the forefront of their lives, and there are other competing issues that can promote illicit drug use. Also of importance is the function of substance use as a coping mechanism. And in this prospective study conducted by Gerard and colleagues, they explored the hypothesis that Black adolescents who endorse use of substances as a way of coping with stress will respond to cumulative experience of discrimination with increased substance use. They found here that the interaction between racial discrimination and coping predicted a change in substance use over time. So specifically, the dotted line there, you can see that racial discrimination was associated with an increase in substance use over time, controlling for previous use for high coping adolescents, but not for low coping adolescents. And this finding supports the stress coping theory that people use substances in an effort to cope with the stress associated with discrimination. Perceived discrimination specific to substance use has been defined as being discriminated against, prevented from doing something, or being hassled or made to feel inferior because of drug use. The prevalence estimates of this type of discrimination ranges from 20 to about 75%. And these studies that are isolated and presented here have all been conducted in North America with varying sample sizes and populations. Predictors of perceived discrimination specific to substance use include being younger, white race, being homeless, and having clinically significant mental health symptoms, among other predictors. And men and women who have reported using heroin have been shown to be significantly more likely to report discrimination due to drug use compared to cocaine, individuals who use cocaine. And this study is significant and important because Crawford and colleagues took this study one step further, and they acknowledged that there are high rates of incarceration among men and women who use drugs. And what they did was they wanted to tease the effect out, this effect out. So they wanted to look at how they wanted to tease the effect of discrimination due to incarceration among those who reported drug use discrimination. So after accounting for discrimination due to incarceration, what was interesting was the association between heroin use and drug discrimination persisted. Finally, discrimination due to drug use has been significantly associated with adverse mental health, as was shown with racial discrimination, and also a number of chronic health conditions. Experiences of discrimination in healthcare settings may contribute to disparities in substance abuse treatment outcomes. So the prevalence of discrimination in a mental health or substance abuse setting has been shown to be 3 times higher for Blacks and Latinos compared to that of whites. And in another study, the greater perceived discrimination from NSP staff was associated with past month injecting risk practices. And this second study really highlights the fact that NSP staff need to be aware that although they work in a model that is usually non-judgmental, their clients may still have a heightened sensitivity to discrimination, which can then have negative consequences for the ongoing engagement of risk practices. So in discussing discrimination, it's also noteworthy to make mention of stigma and its role in substance use. So in a 2016 study by Kulesa and colleagues, they sought to assess implicit and explicit beliefs about people who inject drugs. Participants implicitly associated people who inject drugs with deserving punishment as opposed to help, indicating the presence of addicted stigma-related implicit beliefs. However, this bias was not evident when they looked at explicit measure of the explicit measure of beliefs about people who inject drugs. So this result is important because it suggests that we need to identify conditions under which implicit bias might influence behavior and increase the likelihood of increased risk practices. And this may sound intuitive, but us as researchers need to be mindful as well as to how we refer to women and men who engage in drug use and alcohol use. In another investigation conducted by Kelly and Westerhoff, they showed that among trained mental health professionals, exposure to the terms having a substance use disorder and the term a substance abuser evoked systematically different judgments. Specifically, the term substance abuser, they found, may perpetuate stigmatizing attitudes. So as important as it is to acknowledge the role of stigma in substance use, we need to extend this to look at the context of methadone treatment as it relates to stigma. An emerging work by Dr. Laramie Smith at UCSD and her colleagues has applied stigma theory to assess the ways in which substance use stigma and stigma related to methadone treatment for opioid dependence may negatively impact treatment success. So based on a cross-sectional survey administered to about 93 participants who had been enrolled in methadone treatment for at least 12 months, treatment outcomes were uniquely affected by stigma type. So for example, enacted substance use stigma was associated with readiness to reduce heroin use and injecting heroin in the past 30 days. So what her work shows is that it suggests that it is important to attend both to past experiences of substance use stigma, as well as concerns that one will be stigmatized in the future due to their methadone treatment status. So we need to really be mindful of this if we would like to optimize methadone treatment outcomes in opioid dependence populations. And I'd like to briefly shine the light on incarcerated women. Dr. Strathy mentioned, the burden of drug use among incarcerated populations, but I'd like to hone in on women and highlight that women often experience co-occurring issues, and specifically among incarcerated women, they experience high rates of substance use, mental disorders, among many other health problems. And so an interesting paper that was recently published by Marotta sought to examine child adversity and substance use among both incarcerated men and women. And this study is important because most studies focused on incarcerated settings focus on a single adversity, and fewer studies have examined sex differences in this linkage. So they did a really good job at examining sex differences and looking at multiple child adversities. And what they found was pretty interesting in that women who had experienced child sexual abuse, they were more likely to report substance use disorder or alcohol dependence. Whereas for men who had experienced child sexual abuse, this finding, they were less likely to report substance use disorder. For physical abuse, as a child, there were no sex differences observed across the board for substance use disorder or alcohol dependence. And when we look at injection drug use, another interesting finding emerged, whereas only for women, those experiencing child sexual abuse were more likely to report injection drug use, and the opposite occurred for physical abuse as a child, where only men were more likely to report injection drug use. So I've touched upon, 4 sources of traumatic stress and as it relates to addiction. And now I'd like to briefly highlight the role of epigenetics in addiction. And epigenetics can be thought of occurring at the individual or biological level, and can be influenced by our environment, specifically our social and physical environment. Epigenetics is defined as the study of heritable changes in visible physical characteristics and also overall health, disease history, and behavior that are not linked to changes in the underlying DNA sequence. So epigenetic processes are alterations in gene expressions that occur, and these epigenetic processes have been implicated in addiction. A 2016 study conducted by researchers in the UK showed that variations in epigenetics found at birth were associated with higher levels of substance use during teenage years and an earlier onset of substance use. The findings provide some insights into the relationship between epigenetics and addiction and highlight birth as a potentially sensitive window of biological vulnerability. Other connections between behavior and epigenetics have been made. For instance, people who commit suicide have been shown to have less ribosomal RNA genes than those who die from other causes. Children who face abuse have had an epigenetic tag alteration on a particular gene. And drugs like cocaine, methamphetamine trigger epigenetic changes which can remain in place long after the drug is out of the system. So a few weeks ago, emerging evidence was released that suggests that the consequences of mistreatment in childhood can be passed down to generations, affecting a victim's children or the grandchildren, even if they've experienced no abuse themselves. So it's important to understand and keep this in mind when we think about stress, traumatic stress in general, and how this can play a role into addiction. So specific to the epigenetics of addiction, researchers from the Medical University of South Carolina conducted a study to understand the brain mechanism responsible for the rewarding effects of a particular drug and the motivation to seek it, even after long periods of abstinence. And through this, they uncovered an epigenetic reason why casual drug use can produce long-lasting brain changes that increase vulnerability to relapse in individuals suffering from substance use disorders. So as important as it is to understand epigenetics and the underlying mechanisms linked to addiction and relapse, it's also important to utilize epigenetics when we think about treatment research and to develop different treatment modalities to target addiction. So this brings us to treatment to target epigenetic scars. And Dr. Nestler, a leader in the field of epigenetics and addiction, he coined this term. And what this term refers to is epigenetic changes that occur in response to drugs. In this recent study, researchers found that hundreds of genes underwent methylation while a drug-addicted participant underwent withdrawal. Many of the genes that were methylated were also genes that have been implicated previously in drug addiction. Interestingly, participants that received during the withdrawal state a drug that inhibits methylation reversed the addictive behaviors. So this is pretty significant and lends itself to further investigation as we continue to look for different treatment modalities based on epigenetics and social instructional, that also account for social instructional underlying factors. So with that, I would like to conclude our address, and I hope that you all have learned. I certainly continue to learn every day, and Dr. Strathdee and I shared with you today the social and structural processes that are critical and important in contributing significantly to addiction and its health consequences. We shared with you a snapshot. There's many, many more. It's very important to intervene on these underlying factors that could ultimately prevent downstream effects. And when we look at the cellular mechanisms of drug addiction, so through epigenetics and other approaches, it's important to understand and keep in mind these underlying social and structural drivers that may also influence the whole mechanisms and epigenetic processes. And I'd like to close by saying that us as collective addiction researchers need to be advocates and change agents. We need to be mindful of these social and structural issues, and we need to not sweep them under the rug. And in that way, that's the only way we're going to make a dent in research as well as treatment and service provisions and interventions for men and women suffering from drug abuse. Okay, and last but not least, I would like to shine a light on this slide, and it's a really critical slide in terms of promoting activism and advocacy in the work that we do. So it's not only important to conduct the research, but we need to translate the research into practice, and we need to be the voice for the absenteeism of opioid recovery activists who are in the shadows because of some of these social and structural drivers. So I'd like to acknowledge a few people here who have collaborated, mainly with Dr. Strathdee on her work, and some of our colleagues have been mentioned throughout the talk this afternoon. And thank you.
Nice job. That was excellent. I learned so much from you.
I'd like to thank you both so much for taking the time to share your research and your thoughts with us. And thank you all for attending. Have a great conference for the rest of the week, and enjoy your evening. Thank you.